The first-line treatment of GvHD is and remains the use of steroids, and the use of 2 mg per kilo of steroids. There is a lot of trials that try to improve this treatment with combining with other drugs such as mycophenolate mofetil, including in randomized trials, so very clean randomized trial, and all the trials were disappointing, and steroids remain the gold standards. Some very interesting things also try to look at different doses of steroids, and it seems to be feasible to use lower doses of steroids, in particular with patients that have only mild stage 1 or 2 skin GvHD. It seems to be effective, but in other patients with more severe GvHD, in particular in patients with stage 3 skin GvHD or gut involvement, we have to use these doses of 2 mg per kilo. So we are still waiting for new drugs and new protocols that will help us to improve the response rate. But for now, we don't have a lot to discuss, and maybe what will be promising is to look at the drugs that are using as a second-line treatment that we'll discuss in a few minutes and see if we can use them now in the first-line setting. So for the second-line treatment, so for many years there is no standard second-line treatment and there is no drug that were approved. There was a lot of drugs that were used that give some results, but in most of the case it doesn't work, and the patients are going to need a third and fourth line of treatments, and at the end you will finish to die from the GvHD and the infectious complications. And over the last years we see a new drug that is ruxolitinib that were used for hematological disease, but not for GvHD, and that shows some very promising results, both for acute but also for chronic GvHD. And in the acute GvHD, there was a phase 3 randomized trial that were published very recently in the New England Journal of Medicine, when they compare the use of ruxolitinib for steroid-resistant graft-versus-host disease compared with the best available treatment. And what they find is that the use of ruxolitinib was associated with a significantly higher overall response rate and also a complete response rate at day 28 compared to the best available treatment arm. So it's very promising. Based on the result, ruxolitinib was FDA approved in the US. I don't know if they will be approved in Europe by the EMA, but maybe in the next months or years, we will see. But still, this is the first time we have a positive phase 3 randomized trial for the treatment of graft-versus-host disease. So this is a very, very good news, and we can now say that ruxolitinib may be a new standard second-line treatment for GvHD. Of course, in some patients, we can't use ruxolitinib because there is some side effects. There is a cytopenia. There is also the risk of infectious complications, in particular cytomegalovirus reactivations and virus like that. So we need some alternatives. One of them may be the use of extracorporeal photopheresis, ECP. That is very interesting because it's more an immunomodulatory drug instead of an immunosuppressive drug. So in some very high-risk patients, when we don't want to have a very strong immunosuppression, we can use these drugs. And after, we can also discuss all the other drugs that centers use for years with methotrexate, mycophenolate mofetil, anti-TNF-alpha, and other drugs. But we will have also to say that despite the use of ruxolitinib, there is still some patients that will not respond to ruxolitinib or are going to lose the response. So we still need some other therapeutic strategy, and there is still an unmet need for those patients.